Hi, my name is Olivia Rice. I'm a current PGY2 at Carolinas Medical Center in Charlotte, North Carolina. This study is a cornerstone in a larger multi-center research endeavor known as EMIT Collaborative, and I'd like to thank this group for their previous and ongoing efforts. Disclosures can be found in the program. Standard plate and culture techniques remain the gold standard test to diagnose non-union related infection. Current recommendations include ordering this test in every non-union surgery. This advice stems from surprise positive culture results seen in one of the largest non-union case series to date. 20% of these patients with normal inflammatory markers were found to have a positive intraop culture. Of those with positive cultures, 8 were not treated. 5 of them did well, and 3 of them did not. The magnitude of complications from these 3 patients should not be understated, but these event outcome numbers are really small, which tends to be one of the major challenges not only in non-union studies, but in orthopedic research in general. Data fragility, sometimes measured using a fragility index score, refers to the amount of event rate manipulation required to toggle between significant and insignificant interpretations of the study result. So the most fragile data is commonly seen in underpowered studies where a few patients experience the outcome of interest. In research studies, the lower the power, the higher the chance of misleading statistical results, or type 1 and 2 errors. Likewise, for diagnostic test accuracy, the lower the probability of disease, the higher the chance of misleading test results, namely false positives and negatives. In a different study out of HSS, a third of the patients with positive non-union culture results were presumed false positives, and therefore not treated. All of the patients in this study healed without infectious complications. Misleading or spurious results are encountered daily, from hypothesis testing and research to diagnostic tests used clinically. The map does not always accurately represent its respective territory. Clinically, we often use additional forms of evidence to help us make a diagnosis with more certainty. A landmark paper by Tornetta in 2013 showed that combining the results from 3 separate lab tests, the suspicion for underlying infection dramatically increases if all results are positive or decreases if all lab tests are normal. No diagnostic test is perfect, and because every test is wrong sometimes, the accuracy of results depends heavily upon the context in which the test is ordered. Our clinical suspicion for disease before any tests are ordered is formally called pretest probability. For example, lab test results help guide management in a patient you suspect is infected, but are meaningless in a patient with an ankle sprain. Despite good intentions, we can harm patients with treatments we prescribe, as seen here, where a significant complication rate was noted in patients undergoing antibiotic treatment for deep infection. If a patient is truly infected, the risk of complications is warranted, but forward thinking to second-order consequences allows for better assessment of risks and benefits. The purpose of the study was to assess the potential side effects of doing less. .468 non-unions were available for retrospective analysis between 2 large hospital systems. Only those with aseptic non-unions established by the treating surgeon or preoperative lab values were included for analysis. Initially, infection status was determined by perioperative documentation, and finally by normal laboratory values. Cultures were taken in 58% of aseptic non-union surgeries. There were no major differences between groups except for increased cultures in open fracture non-unions. Outcomes were also similar between groups. When cultures were taken, patients were also more likely to receive a post-op antibiotic prescription. Narrowing in on infection, this table shows similar post-op infection rates between groups and more commonly seen in patients with negative rather than positive culture results. In patients with completely normal preoperative labs, results were congruent. Our overall subsequent infection rate in presumed aseptic non-unions was 8%. With the strategy of selective culturing, our reinfection rates compare favorably to published literature. Many similar debates on culture utility are seen across subspecialties. Previously, cultures taken during primary arthroplasty and clean elective surgeries were commonplace. Not long ago, in open fracture management, it was recommended to culture wounds during every single surgical debridement. Past or present, the results are the same. microbial culture results are ambiguous when ordered for patients with low probability of disease. Two more studies seen in the bottom rows included a total of 44 nonunions with positive routine cultures deemed spurious and therefore not treated. None of these patients developed a subsequent infection. So in summary, in the right-hand column, you can see that anywhere from 5 to 100% of relevant routine culture results were false positive, calling into question their diagnostic utility. So, is it time to rethink routine culturing in all nonunions? Well, it seems reasonable to incorporate pretest probability of infection into that decision. Repeatedly, we've seen more spurious culture results in relation to lower suspicion for underlying infection. And based on our findings, it appears safe. We're not missing a large number of indolent infections that come back and bite us later on. We feel the impact of false negative cultures much more closely because we can see the infection. So we order more cultures on more patients because we don't want to miss an underlying diagnosis of infection. Unfortunately, the strategy is ineffective. It's like turning up the volume on a static-filled radio channel. The signal and static rise proportionally, leaving us with just more noise. Our results showed that similar to not treating spurious culture results, not ordering them in the first place is also safe, with no increase in subsequent infection rate. With 3 negative lab values, the probability of infection drops below 20%. Over the past decade, this finding led to discontinuation of nuclear imaging, a previously commonplace diagnostic test for infection with questionable utility. We believe the same logic can be applied to microbial cultures. While 1 in 5 patients may still have an underlying infection, it appears that cultures will not help us correctly identify that one patient. In the near future, we aim to investigate the second-order consequences of misdiagnosis and treatment as well. So in conclusion, our preliminary data suggests in patients with low probability of infection, there is no clear benefit of obtaining routine cultures during nonunion surgery. Thank you.